It's funny, everybody's in Washington today. Well, there's an explanation. When the '08 campaign was run, the person elected president did so on a platform of coverage for all Americans. Indeed, every candidate was pushing that idea. Well, the new president has appointed an incredibly high-level commission. The hearings are scheduled on access, sure, but hearings are also scheduled on payment for doctors, costs, the mode of medical practice, a whole range of subjects. Are they interrelated?
All these things are tied together. There's no question about that.
Okay. Well, this morning's hearing was about payment. And Tom, you testified to the commission. And there was a direct question to you. What is the future of fee for service? What did you say?
How about those Red Sox? And, no, I think it's got to change, and we all know it. And the question is, how can it change without causing tremendous disruption to the providers and to the patients they take care of?
Now, are you feeding us a euphemism? When you say it's got to change, do you really mean it's got to go away?
I think that over the next several years, it will not be viable for folks who are just taking fee-for-service without any kind of incentive for things other than, volume.
Now, Charles, what would you have testified?
I think what I would have said is that fee-for-service is probably not going to go away because we muddle in the healthcare space when it comes to reimbursement because we don't know what else to do. I actually hope that what Harry says is that primary care needs to be treated with a lot more respect by the payer community generally and by Medicare in particular, because Medicare is, for all intents and purposes, the payer who sets the rules of the game for everybody else. And Medicare is procedure-driven, it's technology-driven, and it doesn't pay for time. It pays for transactions.
Arnie, what would you have said?
I would have said we're going to learn the lessons from the early 90s. And if there was a lesson from the failed Clinton health reform, and there were a couple, it was let's not try to radically force a completely new system down America's mouth because they will not take it. We had alliances and we had HIPICs and we had 1,300 pages of change that we were going to put forth, and it was almost dead on arrival.
All right, let me give you some texture about Harry Oldman. He practices with two other physicians. It's a three-physician family practice. He's got the typical cluttered facility, lots of file cabinets. Karen, you tell me, what is the optimum compensation scheme?
Well, for Harry, I think what we need to move to is give him the option of being a patient-centered medical home. What do I mean by that? That practice should be rewarded for taking accountability, for making sure those patients are getting appropriate counseling, they're up to date with their preventive care. If they're overdue for a diabetes checkup that they've been told to come in, the doctor wants to see you. And that means, in addition to fee-for-service, a monthly panel fee for being a medical home. So it's moving to what I think of as a blended system of payment, which has worked very well in Denmark, and where people have well-established relationships with primary care, and where compensation for primary care is on a par or even higher than compensation for specialty care.
Tom, now you tell me, is he ready to be a home, a center?
No, I think Harry needs help taking care of those folks. I don't think Harry can do it by himself, no matter how hard he tries. And I think the theme is team care these days, and it's not. We obviously need teams for like the really sick people, but for the not sick people, the people who need help with their weight and their blood pressure and smoking cessation, it shouldn't be Harry who's sort of following up to see if they stop smoking. And Harry's all practice has to get paid in a way that it can support a team around them. So I think this medical home concept is critical. Because, we need physicians to trust non-physicians to do things, that they don't have to see every single thing.
But Harry's not set up to be a team.
Harry's practice needs help evolving in that way.
Yeah.
I think what I would do for Harry's practice in particular is I would add a fee for consultation and advice. I think there's absolutely an opportunity for us to pay physicians for their cognitive advice and counsel to their patients, which would be different from, I think, your healthier patients to your sicker ones. So that's one thing, and Medicare can do that, insurers could do that if it wanted to. The second thing that I would do is I would absolutely not go the road of a primary care case management system. Medicaid programs have tried that for years, and it doesn't effectively change the clinical outcomes or the physician engagement. If, on the other hand, you were to give the physician a budget that the physician, he or she, can use to direct to outside supportive agencies, whether that's social work or counseling or dietitians, et cetera, now you have the physicians with a pool of resources to assemble a team of individuals who can support patient care. But I think that the crux of making the difference here is not to destroy the fee-for-service system, but to add to it, to make it a valuable use of a physician's time to have a conversation, an intimate, relevant, purposeful, directed conversation with his or her patients on a regular basis.
In fact, speaking for Harry, I have to say, I don't care all that much about how I get paid. I'm very interested in getting paid. I want to get paid. But I want back my time, which you keep taking away from me, not you, but this system. I don't have time. I spend it doing everything but medical care. It comes out of what I can do with my patients. I want my professionalism back. And I want some relief from constantly being tortured by third parties like lawyers.
And also, Harry is telling his 25-year-old daughter, don't go to medical school, don't be a doctor. And the why, what is Harry thinking, is exactly that. It's more red tape, it's more paperwork, and all I want to do is heal.
And but we have a cost problem in the country
but the cost
that
problem,
we better get to.
Let's get to it then real quick. Because what happened in the elections last year, we're in 2009, was that the uninsured, which is a huge issue, 47 million people uncovered, they die sooner, they get care later, it is a terrible problem. If the cost is too high, it drives up the ranks of the uninsured. And then you get back to the causes of cost, and that's where we're at this hearing today with fee-for-service. Because I do believe that if you're incentivizing the system by the number of procedures done, heart transplants, heart surgery, numbers of patients, and that's the way you're paying, so therefore you have to see 25 patients instead of 15 a day, and you can't talk to them about their smoking, we got a problem. So the incentive system today for physicians is to do more cases, more procedures. Fee-for-service, however, you don't have to blow it up, because I agree, it's part of our American system. But you do have to change what the service is. Right now we pay on volumes, and what we need to be doing is paying on value, outcomes, how good a job, and rewarding that outcome.
Okay, one thing is clear. Harry's got to change. I mean, you raised an interesting point, Art. He sits there with his paper records, filling out forms. What are we going to do about that, Tom?
It's a big problem, and I don't think Harry can fix that. I think that it would help if the insurance companies could get together on this simplification thing, but for them to do it, they need the businesses to get behind it. It's a collective problem, reducing the bureaucracy.
There's one thing I don't understand. As I wander around, I see people with computers. When I go to my doctor, he's constantly shuffling paper. What is that?
There are so many healthcare technology options out there. And the reality is, any physician, from a sole practitioner to a large medical group, can outsource all of that paperwork to any one of a number of companies who will take care of that for them.
Why doesn't my doctor do it?
I'll start. I'm sure that the doctors in the room can give you credible answers, but one reason is that it is changed and they would rather not deal with it. One reason that it's not affordable. One reason is that you can outsource all these things and still have all this leftover paper. And I think part of it is that there's I believe, a focus on the medical professional on practicing medicine, not technology and business. And so if you ask a physician, where am I going to spend my time? Researching how to outsource all of my technology, or reading a journal that's going to help me practice better medicine, or touching a patient, I would rather do one of the other two than figure out what company to hire to manage my office.